Today, we're going to tackle one of the most common and frankly frustrating challenges in cardiovascular risk reduction. What do you do when a patient tells you they just can't take their statin?
So let's just start with a number it's pretty sobering. 60%. That's how many patients stop taking their statin therapy in just 2 years. This isn't just a small compliance issue, it is a massive roadblock to preventing cardiovascular events, and it really highlights why having a clear plan is so absolutely critical.
So, in this explainer, we're going to walk through a really practical clinical pathway. We'll start by looking at the scale of the problem, then we'll move into how to properly diagnose it, cover the crucial step of the rechallenge, explore our ever-expanding toolkit of non-statin therapies, and we'll wrap it all up with a patient-centered playbook to bring it all together.
Okay, first step, let's really frame the stakes here. The clinical impact when patients don't take their medication is significant, and truly understanding that is key to motivating our entire approach.
Just think about the real cost of stopping the medication. One major study found that patients who stopped their statins within 6 months faced a 26% greater risk of a heart attack and an 18% greater risk of death. I mean, this tells us everything we need to know. Stopping a statin isn't some neutral decision. It measurably and dangerously increases risk.
All right, so how do we systematically figure this out? When a patient reports symptoms, our first job is really to be a detective, to separate true pharmacological intolerances from all the other possibilities, including that incredibly powerful nocebo effect.
The National Lipid Association's 2022 statement gives us a really clear, actionable definition. It's got 2 key parts. First, the symptoms have to get better with dose changes, and second, the patient must have tried at least 2 different statins. And crucially, this definition also separates partial from complete intolerance, which is a vital concept for how we build our management strategy.
So when a patient comes in reporting muscle pain, you can think of it as having 4 potential paths. The cause could be totally unrelated. Maybe they just overdid it at the gym. It could be an interaction with another drug or disease, or it could be true partial or complete statin intolerance. And each one of those paths demands a completely different clinical approach. Because of that, our first clinical step is always to rule out reversible causes. We have to screen for underlying conditions like hypothyroidism or uncontrolled diabetes. And we absolutely have to check for other drugs, things like steroids or certain beta blockers that can cause symptoms that just mimic a statin side effect.
Now, let's talk about the power of the nocebo effect, because this is fascinating. In the Big Gauss 3 trial, they took patients with a history of statin intolerance. And get this, over a quarter of them reported the exact same muscle symptoms while they were taking a placebo, a sugar pill. This tells us that while true intolerance is definitely real, affecting about 5 to 9% of patients, the expectation of side effects is a huge factor we have to address.
So once we've addressed those reversible causes, and we've had a good conversation about the nocebo effect, the next step isn't to just give up, not at all. It's to attempt a rechallenge. The question is, how can we do this systematically to get the best chance of success? The evidence for trying again is just overwhelming. As this major study concludes, most of those initial adverse events aren't class-wide effects. Giving up after that first try is almost always premature. In fact, a study out of Brigham and Women's Hospital found that an incredible 92% of rechallenged patients were still successfully taking a statin 1 year later. That single statistic right there should fundamentally change how we approach that first report of a side effect. So how do we do it? The SLAP algorithm gives us a simple, memorable framework. First, you switch statins, maybe from a lipophilic one like atorvastatin to a hydrophilic one like rosuvastatin. Next, try a lower dose. If that doesn't work, consider an alternate dosing schedule, like every other day. And finally, if you need to, use polypharmacy by combining a low-tolerated statin dose with a non-statin agent.
So, what about our next strategy? For patients with partial intolerance, or for that small group with complete intolerance, we now have a powerful armamentarium of non-statin therapies.
We have moved so far beyond a statin or nothing world. We've got ezetimibe for a solid 15 to 22% LDL reduction. We have bempedoic acid, which is liver specific and can give you almost a 40% reduction when you combine it with ezetimibe. And of course, the big guns, the PCSK9 inhibitors, can lower LDL by 50 to 60%. And here's the key. All of these are now backed by cardiovascular outcomes data. And for our highest risk patients, the ones with established ASCVD, the entire consensus is shifting. Instead of this slow, sequential approach, guidelines are now recommending starting with combination therapy, like a statin plus ezetimibe, right from the beginning to get those LDL goals much, much faster. Finally, none of these strategies, none of these algorithms, none of these drugs work without the most important component of all. This is our patient-centered playbook, and it is all about achieving adherence through partnership. The foundation of success is communication. We have to listen and really validate our patients' concerns. Then we have to educate them on the why. We're not just treating a number on a lab report, we're preventing heart attacks and strokes. This leads to shared decision-making, where we can use tools like a personalized lipid intervention plan and constantly reinforce the powerful message that any amount of evidence-based therapy is better than none at all. This quote from Dr. Celine Varani just perfectly captures the heart of that conversation. When we reframe the goal from lowering a lab value to preventing a life-altering event, the patient's motivation and their whole understanding of the risk-reward balance changes dramatically. So ultimately, the management of so-called statin intolerance has evolved. It's no longer a single drug dilemma, but a multifaceted challenge with a rich therapeutic toolkit. By combining systematic diagnosis, a persistent re-challenge, smart use of our new therapies, and a true patient partnership, we are empowered to help nearly every single patient achieve their risk reduction goals.